Hi, everyone, and welcome to this presentation on preventing falls and injuries. We're excited to be hosting this series through our Senior Center Without Walls program. Just before we begin, I'm just going to go over a few housekeeping items. Oh, by the way, my name's Laurie Stamen, and I am the manager of the Seniors Resource Center in Metchosin. So I'm recording this event, and we're going to be posting it on our YouTube channel, Metchosin Seniors. And I'll ask that you keep your microphone muted unless you have a question, and there will be time for questions after the presentation. And joining me today is Bobbi Symes she's an instructor at the Canadian Fall Prevention Curriculum and the Strategies and Actions for Independent Living programs at Continuing Studies at UVic. She's also the assistant director at United Way of the Lower Mainland. And Bobbi's been involved in novel fall and injury prevention research, including video capture of real-life falls in long-term care and compliant flooring and resident rooms and stick-on hip protectors. She has an interdisciplinary Master of Arts degree with a focus on education and community development. And as I said, today she's going to be giving us a prevention on how to prevent falls and injuries. And so I'm going to turn over the mic to you, Bobbi. Welcome.
Thank you, Laurie, for that introduction. And so great to be here and to talk to you guys today. As you'll see in some of my stories and some of the presentation, fall and injury prevention is near and dear to my heart as it relates to families, my own parents. I'll share some stories there, but I'm going to share my screen. I do have a few slides that you can, if you've got video or visual, you can follow along with me. Okay, hopefully it worked that time. And I'm just going to move the videos of all your faces so I can see my screen. All right. Thanks, everyone, for joining me today. As Laurie had said, my name is Bobbi, and a little bit about me, and she covered some of it, is really about my interest in fall and injury prevention. As Laurie mentioned, before coming to the United Way of British Columbia, I was a research manager at Simon Fraser University in their Injury Prevention and Mobility Lab. And there we studied falls, both in a lab setting where we were able to use something that we call the perturbation platform, which is just a big fancy name for a moving floor, where really we could make it move in any direction, back and forth. And it was really a way to see and record how people were falling. So note that we used volunteer students. We weren't using older adults. They had a mat that they were falling on. They had a helmet with cameras. And this is just a way to see, how people would use their arms to get balance, that they would adjust their feet to get balance. And then the other thing that we were able to do is we partnered with 2 long-term care facilities where they had a series of video cameras, which were originally installed for security purposes. But we found that we were able to use those falls, which were set up in common areas, to actually see how, when, where, why people were falling. And then we were able to then capture those videos, bring them back to our lab setting, where again, we use students that would do like an analysis of the videos that we were watching. And so over the years, we were able to capture thousands of falls. And we were able to see basically, like I said, how, when, why older adults were falling within these two homes. So today's webinar, you're going to see examples of some of those falls. And although they're in a long-term care setting, a lot of them were set up in a home-like environment. And so that you'd be able to relay some of your learnings today to your own home environment or those of your neighbors and families and friends around you. But I'm sure everybody that's on today's call maybe has been impacted by someone in their life that has fallen, whether it was yourself, a family member, a friend, or someone who participates, in activities in your communities. But prior to working in fall prevention, I didn't really think twice about falls. I mean, I was young, I was probably in my early 30s by the time I got to work in this area. And I hadn't really thought too much about it and the impact, the real impact that it has for older adults in the community. But now I've learned more about it through my work at SFU, how it's impacted me personally. So my parents, as an example, they've lived with me for the past several years, and that was intentionally so that they, had a ground level suite with no stairs. We moved them out of an apartment and got them moved into a nice big wide open concept in our home to be with my family. And they've been here now for several years. And my father, who actually just passed away in August of this year, he actually had a number of falls. And this just goes to show you that doesn't matter how much you know, or how often I'll say I preach to him about safety and fall prevention. It will happen to those around you, up to nobody's fault at all. But one day, so I was home and I was preparing for a presentation much like this one. And my dad, who had just gone out to get the mail, and he had just come home and he had walked up a few stairs to drop off the mail. That was for me and to say good morning. And I always encouraged him to take the short walk down the block to get the mail for us. It was a great excuse for him to go out, get some exercise, physical activity. But one of the things he quite often liked to do was to stand on the third stair up, from the landing. And so I would often just go down to meet him so that he didn't have to walk all the way up the staircase. Anyways, he was curious about what I was doing that day, and I told him I was preparing for a presentation on fall prevention. And then after a few minutes, I headed back upstairs. However, as he turned to go back down to his place, he lost balance on that stair and had a misstep, and he actually tumbled down those 2 or 3 stairs to the landing. And, although I'll say he didn't suffer an injury, both his head and his shoulder actually went through the drywall and put a hole in the wall. And, I'll say, I was super distraught. And I also say that my dad is a complete joker. So what he did in that instance is he said, go and get your camera, because this is a great opportunity, a great photo of what not to do. And so, of course, I helped him up and he was fine. But, those type of life situations, like say, can happen at any given time. And you just don't know when it's going to happen. And I also want to say that I'm super happy that we have a month like November to draw awareness to fall prevention. It can't just be done in 1 month, but at least we've got this month to really focus and talk about it. It really has to be embedded in everything that we do, because as we'll talk about today, sometimes it only takes that one fall that can change your life forever. And today we're going to talk about fall and injury prevention, and just really to build awareness about what you can do in your own homes and in your communities. So I want to start off with just talking about how we define a fall, just to put us all on the same page. And for the purpose of the curriculum that I work in, it's about unintentionally, so you're not doing it on purpose, unintentionally coming to rest on the ground, floor, or other level with or without injury. And so I think that's important to talk about when we talk about falling. Some people say, oh, he's not injured, they didn't get injured. When we're talking about falls, we're talking about both those injurious falls as well as the non-injurious falls. Lots of non-injurious falls can eventually lead to one that's a lot more serious, that resulted in some sort of an injury. So I have a question up on the screen here. Some of you, I don't know if all of you can see it, but the question is, falls are the leading cause of injury for seniors. Now, I just want you to think about that for a second. So the leading cause of injury for seniors, and that takes things like car accidents, everything else into consideration. And of course, I asked the question because it is true. And I think that's why it's so important for me and for others to really understand that this is, an area that we need to really pay a lot of close attention to. And later in the presentation, we'll dig in a little bit more about those injurious falls that I was just mentioned. But as I mentioned in the story about my dad, his fall, that one I talked about at least, did not actually lead to an injury. However, it only takes that one injurious falls that can lead to a life-changing consequence, not only for the faller themselves, but of course it's the family, the friends, the care providers, and although I don't like to go there very often, the healthcare system as well. It kind of reminds me of one story that I have of a woman that I had the pleasure of being introduced to in one of the long-term care facilities that we were doing our research in. Her name was Margaret, and Margaret was a lovely woman. She was a wife, a mother, a grandmother. She lived in her home with her husband. And she was telling me, as I was talking about, her transition from community to the long-term care facility she was in, and she was saying how there was one Thanksgiving weekend where she was making a turkey dinner with her family, and she happened to slip on some grease on the floor, and she fell and she suffered a hip fracture. Margaret was a very strong, independent 70-year-old woman. She lived with her husband in her community. She volunteered. She enjoyed taking walks with her husband. And Margaret never returned home after her fall. After several surgeries from the hip fracture, she was admitted to long-term care, and she passed away due to complications within 6 months of that fall. I tell the story because it's not uncommon. Most older adults who have a serious fall results in this type of a serious injury, they pass away within 12 months of that fall occurring. Falls also lead to negative mental health outcomes. They can lead to things like fear of a future fall if they've suffered a fall, loss of autonomy. It can lead to an increase in isolation as that fear goes around, walking in community and now having that fear of falling. It can lead to confusion, immobilization. It can lead to depression. So in addition to those negative physical and emotional consequences, there are several financial costs to a fall happening. And that's estimated to be about $2 billion nationally on an annual level. So take a look at the following, if you can see them, and if you can't, I'll read them out. Which do you think is true? 1 in 100 British Columbians over the age of 65 will fall once per year. 1 in 50, 1 in 10, or as many as 1 in 3. So just think about that for a minute. 100 British Columbians over the age of 65 falls once per year, or is it 1 in 50 of those older British Columbians? And this is BC, it's not nationwide. 1 in 10, or as many as 3. The answer is actually 1 in 3. It's a staggering number. So each more than 200,000 older adults here in BC will experience 1 or more falls. This will result in more than 10,000 hospitalizations and more than 800 deaths as a direct or indirect result of that fall. And that's more than 2 per day. So let's remember Margaret. She went from roasting a turkey with her family in the hospital to going into long-term care where she passed away 6 months later. So knowing all of this, what can we do differently? How can we change these staggering results and statistics that we're seeing? So we know that we can't prevent falls. That's not going to happen, but we can reduce the number of falls, and more importantly, those injurious falls or those more severe falls. So let's talk just a moment about the factors that make one person more susceptible to a fall over another. Let's start by looking at why older adults fall. And from there, we can look at individual risk factors across 4 different domains. We're going to look at things like biological, behavioral, social or economic, and environmental factors. So why do older adults fall? In its most simplistic form, falls occur due to a loss of balance with that inability to recover. So when we're younger, we tend to have stronger muscles, we have better gait, we have a quicker reaction time in most cases, which means better balance and better ability to recover if we do lose that balance. So human balance is very complex. It requires several different systems to work together to control balance and prevent falls. So it's important for us to discuss when we better understand what affects the balance the system has. So we can better understand the causes of falling, which helps us to identify risk factors, which in turn help us to make changes in hopes of reducing the persons at risk of falling. So what are these complex systems that we talk about? What work together to control balance and help prevent us from falling? So bear with me for a minute as we go through some long wording that you might not be familiar with, but they're really obvious once we actually define what they mean. And they'll all make sense as we provide some examples. So when we're talking about individual risk factors for falls, we're going to talk about things like the visual. Visual tells our brain if it's light or dark, where we are, where objects are in relation to us. We talk about the vestibular, which is really the fluid in our inner ear that tells our brain whether or not we're leaning forward or we're leaning backwards, and whether or not we're stationary or whether or not we're moving. We have sensors. We use sensors in the muscles and joints throughout our body that tell our brain if we're walking on a hard surface or a soft surface, whether or not we're walking on a level ground or a slope. And then we've got our system of muscles, or our musculoskeletal system, and that provides a framework and strength that holds the body upright and allows for movement. So one example, and I'm not encouraging you to do this right now, but just kind of think through this, and even try it if you're in a safe place and have somebody around you. So if I were to ask you to stand up, and just stand with your feet, just normal width apart, and just stand there for a moment and feel your body. You might even feel your body start to sway a little bit, because it's kind of awkward sometimes with straight legs to just sort of stand there. Get a sense of what that feels like. Then once you're comfortable doing that, I would then just say, how do you think it would feel if I were to ask you to close your eyes? Now, I don't want you to do this because I wouldn't want anybody to have a fall while we're doing this. But if you're just standing there and you've got someone beside you, close your eyes for a second, and you'll start to feel your body even sort of sway back and forth a little bit as your body adjusts to that lack of vision, and things go dark on you. And then I often add, and so you sort of get that feeling of, okay, I get the visual, right? And how that sort of affects my balance and what that looks like. And then you can sort of open your eyes again, recalibrate. And then it's things like lift one leg, lift one foot just gently off the floor. So you're losing now sort of that sensory, you're losing that sense of balance with that extra foot on the floor, and you start to sway again. So now you've seen what it's like when it's dark, you've seen what it's like when you lift one foot off the ground. And so these are all very obvious, but that's really what all of these 4 things that we're talking about. And then the final thing, which I think gives these people the most issues, myself being one, is when I ask you to stand up, close your eyes, and then lift that foot. So here is just an example as how you can have compounding different risk factors. If you just lose your sight, it's one thing. If you lose a limb, it's another. But then, you lose your hearing, your eyes, maybe you've got cataracts, or, now you've got other sort of impairments. It always will increase your risk the more things that are there for you. So I tell that just to talk about how each system provides information to the brain, and all of that helps keep us upright. So in younger people, these systems, they've built up this redundancy or this overlap. So if one's not working, the others will compensate for that. However, age-related changes, they will gradually reduce the overlap in between these systems. So diagnoses such as Parkinson's, arthritis, loss of vision, decrease or loss of hearing, they'll change how our balance systems work and influence our ability to recover balance. So again, we go back to that definition of why people fall, and often it's loss of balance, which is causing the fall to happen in the first place, or not being able to recover that balance. So when all of these things are working correctly, on our balance system is automatic, and they'll assist us in recovering balance. So an example of this might be as simple as shifting a foot. That's an automatic balance recovery thing that we do without even thinking about it, or even reaching out for something. If we start to lost balance, you reach out to grasp something around you to help to maintain your balance. So many risk factors have been identified when it comes to falling among older adults. And these are all related to their ability to maintain and recover balance. So in addition to being affected by gradual age-related changes, the balance system also is being affected by the things going on external around us. So examples might be medications, a lack of exercise, even inappropriate footwear. And then we have the social, economic, and environmental hazards that don't directly affect our balance system, but they can create additional challenges for us. So for example, a low income can result in a poor diet, which can lead to muscle loss, and that can in turn affect one's ability to recover or loss of balance. So the table shown on the screen, if you can see it, is an example of some of the risk factors proven to be associated with an increased risk of falling. And we just refer to this to the BBSE model, which is just the biological, behavioral, social, environmental. Excuse me. In light of time, I'm not going to go through and read each of these in depth, how each contributes to the risk of falls. And there's tons of great resources that I can share with Lori so that she can help distribute. But what's important to note is that it can be easy to get caught up in looking at or making changes to just one of these risk factors. And it's important to remember that it's often the broader picture and that we often have to take this holistic approach as there are several risk factors at play. So I'm going to take this opportunity now to share with you a video. It's an educational video that was developed by myself and my colleagues, the research team at SFU. And although the video, as I mentioned earlier, is about managing the risk and prevention of injury in long-term care, much of the information that you'll learn is transferable to home and community. So compared to community sessions, community settings, such as people's homes, people in residential care or long-term care traditionally have more health problems. They take more medications, they have more mobility issues, they have compounding the effect of the risk of the falls. However, as we continue to promote aging in place and we develop programs that allow older adults and encourage older adults to remain in their home and community, we're starting to narrow that gap between individuals that we're seeing living in communities and those that we see in the residential homes. You will see some of the real life falls that we captured in these two long-term care facilities. And this is where I do need to insert a bit of a disclaimer that these falls can be difficult to watch. It's not easy to watch somebody fall. And I'll also want to say that all of these individuals, they consented to the use of the video footage. Their family members felt that, and them felt that it was very strongly that education and evidence of these falls would help to develop the awareness so that we can all work together to reduce the number of falls, and especially these injurious falls. So the video is about 12 minutes long. And if you have any issues, we'll remain here. You can, if you can't hear, or if there's any glitches with the video, hopefully not, we did test it in advance, but hopefully you'll be able to enjoy this video.
Falls are the #1 cause of injury in older adults, including 95% of hip fractures and 60% of head injuries. Over the past 5 years, we've partnered with 2 long-term care facilities in order to capture real-life falls with networks of digital video cameras. These are providing important new insight on the cause and circumstances of these events, and also important evidence on the factors that separate injurious and non-injurious falls. The most common cause of falls, accounting for 40% of all cases, is what we call incorrect weight shifting. This might occur when the trunk moves too far from the base of support provided by the feet during an activity like rising. It also occurs due to a misstep during walking. This is what we might call an internal perturbation to balance as opposed to an external perturbation, like a trip. Trips were in fact common. They were the second most common cause, accounting for 20% of cases. Also common were cases of loss of support with an external object or collapse. In terms of the activity at the time of the fall, we found that falls were equally common during sitting down and during standing as they were during walking. Now, the importance of these results is that they provide an understanding of the combination of cause and activity in order to guide techniques to screen risk for falls and also approaches to design strategies to prevent falls.
This video starts with a very positive image of an older man who's enjoying a social event and being very physically active. The last thing we would want to do as staff members in this facility is to stop such events or limit his physical activity. I think the important point is that we probably cannot reduce all falls, particularly among high-risk populations such as residential care facilities. However, there are a number of things that we can do to reduce his risk of falls and hopefully to prevent falls and resulting injuries. And these fall under three main categories. The first is to record information about all falls. Secondly, we need to assess the risk, and this should be done quite systematically and comprehensively, and that includes assessing his mobility and gait and strength and balance, but it also includes looking at his acute, if they exist, or chronic conditions that may contribute to his risk of falls, and any medications that he may be taking. In addition, we should be assessing the environmental risks that exist throughout the whole facility and recording those and hopefully ameliorating them. And finally, we should be assessing the use of equipment, mobility aids and other equipment in the building to see if they are appropriate for that individual and if they are working to reduce falls, or maybe in some case they increase the risk of falling. And finally, we should be putting all this into a prevention package based on the individual risk profile, but also the facility-wide risk profile, and to continue to update that on an ongoing basis as changes happen for the individual, if his health condition changes, or after a fall.
Falls are difficult to prevent due to the numerous factors that influence risk for falls. The approach that we need to take is to consider physiological risk factors as well as environmental and situational factors. One of the challenges for us is linking the video evidence of the circumstances of the fall to the clinical context. Medications, disease diagnoses, functional and cognitive status.
I worry about polypharmacy, or the number of medications that she's on. And we know in residential care that's a concern. Medications that cause concern would be medications that cause side effects such as drowsiness, dizziness, gait disturbances, visual disturbances. The American Geriatric Society has just reviewed the Beers criteria in 2012, and this is a systematic review where they've looked at all the different drugs and which ones are potentially inappropriate medications for older adults. And they've identified 6 different categories for older adults, which will put them at risk for falls and injury from falls. And those categories include antipsychotics, antidepressants, and also anticonvulsants, benzodiazepines, and non-benzodiazepine hypnotics. But also to consider, there's another drug group, the anticoagulants, which if a person does fall and they're on an anticoagulant, that puts them at increased risk for injury from falls. Healthcare practitioners can do a great deal by having regular systematic medication reviews. We know that that makes a difference. And while reviewing the medications, asking 3 questions. The first question being, is the benefit of the medication still outweighing the risk of the side effects? The second question would be, if the person still requires this medication, is there another one that has less side effects? And the third question would be, if they still need to be on the medication, could it be at a lower dose? When working with older adults and medications, it would be great if we could all have the philosophy that less is more.
In analyzing the videos, we also looked at what happens during the descent and impact stage of the fall. Again, our interest here is in understanding what separates falls that cause injury from those that don't cause injury. One observation was that 37% of falls in this population resulted in head impact. Compliant flooring represents one promising intervention to reduce the risk for head injury in the event of a fall that causes head impact. But there's also evidence of the importance of exercise, and in particular, resistance training for the upper limb. Normally, what we rely on during a fall is safe landing responses, so that we can fall and we can protect ourselves and not suffer significant injury. An important safe landing response is the ability to arrest the fall with the outstretched hands and avoid head impact. In analyzing the videos, we actually found that among older adults in long-term care, this protective response was intact in the sense that 74% of the falls involved impact to the hands. But what we found was that impact to the hands was not effective in preventing impact to the head. Often what we saw was simply crumbling of the arms. So it seems like poor muscle strength may be the factor here, that individuals are getting their arms out, but they're unable to slow down the head and the trunk and prevent head impact. So this is certainly suggesting an important role of resistance training exercises to enhance upper limb strength and the ability to prevent head impact.
One of the things available in care facilities for prevention of hip fractures are hip protectors. Hip protectors are garments or undergarments with padding that.
Okay, I'll end it there. The only reason why is because we go into garments worn in long-term care, and things like compliant flooring in resident rooms, and I know most of everybody here is still in their homes and in their communities, and so, but I do want to just pause it there, just to see if there's any questions from anybody of anything that we've talked about so far before we move on, or the video itself, or any first reactions to seeing some of those videos or some of those falls, because it can be really difficult. Karen, go ahead.
Hi.
Hi.
Thank you. I fell recently, and it actually, what I was doing was, I had been in a senior center and I was walking to the vehicle, and the toe of my shoe caught a speed bump, and I fell forward, and luckily I did not break any bones, minor scrapes and brain and that kind of thing. But my question is, because I have hypertension, about a year or two ago, my medication was increased in strength. And both of the medications that I take for that particular illness cause dizziness. And so I'm starting to think that perhaps that's something I need to speak to my family physician about. I'm also wondering if a cane, having a cane with me is a good idea.
Thank you for sharing your story, Karen. It's not easy. And I would say, any given time, always have an open conversation with your doctor about the different medications that you're on. As, Gina, who's the RN that was talking about polypharmacy, was saying, sometimes it's, looking at the medications that you're on, what are the after facts, what are you feeling because of those medications, like you're saying, dizziness, and are there ways to reduce the medications? Are there other medications that might not have those side effects that you could consider? So that's first and foremost, be open to have those conversations with your physician. And I think that they would encourage you to have that, because it's always a good opportunity to then sort of say, okay, let's see what else you're on. Like, how are they competing with each other? You know, what could we maybe take you off of that are, you know, causing some of these side effects as opposed to the hypertension medication? Your other question around use of a device like a cane. Absolutely. I mean, sometimes the use of devices like walkers and canes, they're not being used even when people could use them, because there's a feel or perception of how other people are going to look at them in community when they're now using an aid. And I always say, you be the advocate for yourself. You know, it doesn't matter. It shows everybody around you that it doesn't matter, that it's your safety. You would rather be out in community using a cane than have a fall and no longer be able to live in your home. And I think being able to have the courage to do that and know that nobody's going to think any less of you for having that cane. I highly encourage it. I would also say that if you are going to go to a cane, make sure that you've got somebody with you that understands the different types of canes. Make sure it's the right length, make sure it has the right grip. There's lots of different canes available. And the last thing we want to do is have you using a device that's actually not the right size and fit for you. So that would be my only other encouragement with the use of the cane. But a cane can very much be useful as it relates to once you get used to using it, that will prevent you from falling for sure.
Well, thank you very much for your help.
Thanks, Karen. Go ahead, Lori.
Just on that topic, what about walking sticks? Would that be just as good outdoors as having a cane?
Yeah, walking sticks are actually really good because, again, it's one of those things. It's like giving you a third leg or a third arm, right? It's an extra limb in those situations that if you do stumble or lose balance over any given time, you can move. Like, think of yourself, if you're walking in a house and you lose balance, there's often a countertop or a wall or something around you that you can sort of reach out for that will prevent you from falling. Often in a wide open place like a parking lot or on a trail, you don't have that. So that's a walking stick, if you will, becomes that sort of safety net that will help you from actually losing balance and going to the ground.
Thank you.
Yeah, again, it's, you know, some people will call a walking stick something that they picked up in the forest. It's a long stick and I'm going to use it. But those sticks can also be very brittle. That could result in more injury if you fall and you put the weight on it, it snaps in half. Now you've got this risk of impact of the stick, you know, harming you further. So again, it's making sure that it's the right device for you so that you don't prevent further harm.
Thank you.
Anybody else have any questions? All right, well, we've got a little bit more time, so I'll just continue with a couple of things. And I've got two case studies that I just want you to think of for a minute, because I think that gives you really good examples about how sort of the socioeconomic situations that we find in, and how two very similar people in very different situations, how their lives can be changed severely. And just think about here, you know, we talked about sort of that BBSS model. I'm going to just flip back to it for a second. So it's things like biological intrinsic. I'm going to have you think about these things as I read the case studies. So it's like biological intrinsic. So we're talking here about mobility, our balance, our gait, our muscle weakness, our gender, our cognition, depression, whether or not there's any history of stroke, Parkinson's, hypotension, arthritis, visual impairment. We have behavioral. So is there a history of falls there? What medications? Is there alcohol consumption? Are people prone to risk-taking behaviors? Because some people are. Inappropriate footwear. You know, I often say, so many people in their homes, they wear those slip-on slippers. And yes, they're easy and they're convenient, but they're actually a big tripping and slipping hazard. So a footwear, women that wear super high heels, you know, as they get older. And, you know, I always give them a thumbs up and say, you know, kudos to you. I've never worn high heels, but those too can be a risk factor for falls. And it's up to, again, it's up to that person to decide, you know, what type of footwear they're wanting to wear, but it's that conscientious notion that I'm putting myself at risk by doing this to myself, by wearing these things. So there's inappropriate use of assistive devices. And so that's where we talk about sort of the cane. I've seen so many people using walkers inappropriately. So the device itself can become the risk factor for the fall. And then things like poor nutrition, hydration, like drink water, like dehydration is a huge risk factor for falls. So make sure that you keep yourself well hydrated, and same with sleep. You know, sleep is an important function. Then there's things that we call the social or economic factors. So things like lack of support, people around you, that network of friends, living alone, lack of transportation, whether there's language barriers or race or cultural ethnicity, whether or not there's low income or there's poor living conditions. And then the environmental. So there's things like tripping hazards, obstacles in your home, outdoor obstacles. We talk an example, you know, of in the parking lot and over the curb, poor lighting, poor design, stairs, you know, irregularities in the stairs, different heights of stairs, the handrail, no handrail, or handrail not coming all the way down to the stairs. So I just keep these sorts of things in mind as I read out these two case studies. It just gets you to think about the different risk factors that people have in their lives. So case study 1, we have a woman who's 82 years old. She had a stroke about 6 months ago, and that resulted in a permanent left side weakness that partially limits the use of her arm and leg, sorry. She lives in a large urban area in a house that she and her husband have owned for 25 years. She has good access to healthcare services. Her husband's in good health, able to provide many of her care needs. They have the resources to purchase necessary equipment to promote safety, mobility in her home, and to make renovations to their house. She attends a group physiotherapy session twice a week to promote the recovery of her left side weakness. She is underweight for her height. She has no other health problems, not taking any prescription medications. She takes aspirin each day to reduce the risk of another stroke, consumes an average of 1 or 2 glasses of wine each day. She has adult children, grandchildren, close friends who live nearby and who provide support and companionship. So we see this, she's a woman, she's 82 years of age, and she's recently had a stroke. So some of the risk factors, if we go back to that, you know, and I'll just highlight them for you, unless anybody else wants to chime in if I've missed anything. So the stroke, of course, has left her at a risk of falls because she now has weakness that she didn't before. And she only is able to partially use her arm and her leg on that side. So that alone, you know, will give her an increased risk of falls. Important to note that she lives in a large urban area because she probably has resources and supports very close by to her, you know, as opposed to live in a more rural or remote community. She lives in a house that she and her husband have owned for 25 years. So there's familiarity, you know, it's not new, you know, and this is a home that they have the resources to change. They can widen doorways, you know, they can remove certain things. They can, you know, create more space for her in this house. She's underweight for her age. So that's probably a bit of a risk factor right there in terms of, you know, strength. And but she has no other health problems. She's not taking any prescription medications. The 1 or 2 glasses of wine each day, you could potentially say put her at risk, most especially if she's underweight for her age. But you know, to each their own. But she also has she has adult children, she has grandchildren, so she's got a strong social network around her for companionship. Anybody else want to weigh in or say anything about this particular case study and the risk factors for fall that she might have?
Did they mention in that video about taking aspirin or?
No, I don't think that was mentioned in the video.
Okay.
Yeah.
I have nothing then.
Yeah, no, perfect. Yeah, and so the aspirin in and of itself probably doesn't have anything to do with, a potential risk for fall, and it's being used as a preventative measure for stroke. So it depends too, because she's not on any other medications, then for me, that really wouldn't stand out as a risk factor. It's a good prevention for her. All right, so I'm going to go on to the next one, just to sort of give you a view of like the difference, as it relates to this individual, and that, the different risk factors, the biological, behavioral, social, and environmental. So we have another woman who's 82 years old. She too has had a stroke with similar symptoms. However, she lives alone in a small rental unit, to which she recently moved after her husband died following his lengthy illness. She has very few friends, as they moved to a small town in an isolated rural community 3 years earlier so that she could be near her son. 2 years after moving, her son got divorced from his wife, and he moved 500 kilometers away for a new job, and he remarried. She doesn't drive and spends most of the day alone in her apartment watching TV. She has the equivalent of a grade 8 education in her native country of Romania and has limited understanding of the written or spoken English. A friend told her that the income from her husband's pension was too high for her to be eligible to receive a subsidized home support, and she's reluctant to use her small savings to cover the cost of care or equipment. She's using a walker that's on loan from the Red Cross, but she'll need to return it in a few months. She's taking an anticoagulant to reduce the risk of future strokes. She's slightly overweight, high blood pressure that's being controlled by medication, and has recently been prescribed an antidepressant, sleeping pills, after telling her doctor that she wakes often in the night, and she feels lonely and depressed since losing her husband. So here we have two 82-year-old women who recently suffered a stroke, who are finding themselves in very different situations in terms of those risk factors for fall. Does anybody want to offer up some of the significant differences or things that might have jumped out for them that might put them at a greater risk of fall? I can start for sure. So here she lives in a small rental unit. So again, we talked about that other woman living in her home for 25 years, being able to make any modifications she wants, maybe a bigger house with wider hallways, bigger rooms, less clutter. And here we have a woman who lives in a small rental unit. She probably can't make those modifications and probably doesn't really have the space that she needs to. Her husband has passed. So now she's finding herself living on her own without that person that she relied on. It says right here she has few friends and moved to a small town in an isolated rural community. So she probably doesn't have that social network, probably doesn't get out very often. And she moved there to be close to her son, who in turn moved on and moved away, after she had lived there. And now she can't afford to move again and move closer to him. So she spends most of her day alone in her apartment. So there's probably limited physical activity. She's probably weakening, as we go, which increases her risk for falls. Watching TV all day. She doesn't necessarily speak the language, so she might not want to get out as much. She might be very conscientious about her lack of, or be able to communicate with people in her community who don't speak the same language as her. She's low income. So things like not that she's on the subsidized using this walker from Red Cross, but now they're going to take it away from her. So she's going to get used to using this mobility device. And it just makes me cringe at the thought that now they're going to take it away. And the only way that for her to have a mobility device is to pay it on her own, and she can't afford to. So she's going to get used to using a mobility device and then have it taken away from her, which is going to drastically increase her use of her chance of falling, because she no longer has that stability device at her hands. And here we talk about the different medications that she's on. The antidepressant, which is probably causing drowsiness. And she's on sleeping pills on top of that, which is probably going to make her feel dizzy throughout the day. She's waking often in the middle of the night, even though she's on these sleeping pills, which is going to make her tired. And then she just feels lonely and depressed. And so she really doesn't go out very often. So you can see that the difference in terms of the sheer number of risk factors for falls in comparison to the other individual. Any comments or questions on that? Just being a time check. All right, so we just have a couple more slides that I can, and I wanted to just go on into this one just very briefly, because we haven't really talked about, so what do we do? And so I just really wanted to highlight very quickly just some of the things that we can tap into to sort of look and make these changes in our life. So first of all, as we look at this sort of behavior, this model, behavior is at its core, and behavior changes at the center. And it's a common goal for each of these strategies that surround. And in most cases, it's the individual's behavior that is expected to change to reduce the risk. However, that's not always just the case. There's a number of prevention actions that involves change. And that behavior, it actually includes caregivers, care providers, family members, building inspectors, like transportation providers, emergency services. Like it involves everybody. Building on that, we've got equipment. We talked about this a little bit. And a troubling aspect of fall prevention is the degree to which older persons either choose not to use equipment that could reduce their risk of falls. So Karen, thank you for bringing that up. And the second is they use their equipment inappropriately. And like I mentioned before, I can't tell you the number of times that I've seen a walker being used incorrectly that has actually resulted in a fall occurring. So equipment helpful in preventing falls and injuries can include personal alarms. And I say things like personal alarms because, you know, it's sometimes people will just sit on the couch. We find them, they don't get up. And personal alarms could just give little subtle reminders, like go for a little walk around the house. Maybe it's time to get up and get that glass of water. Maybe it's time to go to the bathroom, right? These little things, if we just remind ourselves like, hey, I need to get up and do something. That little walk to the kitchen to get a glass of water can have make a huge difference. Things like walkers, canes, wheelchairs that we talked about earlier. Bath stools or benches in the shower, non-slip rubber mats, walk-in tub or roll-in shower where you've got that opportunity to have that. Toileting aids like a raised seat, urinals and commodes, putting grab bars around your house, you know, pretty cheap to have a couple of good, decent grab bars installed that you can pick up at your local Shoppers or pharmacy. You heard earlier in one of the videos, they started to talk about compliant flooring. So we're starting to look at that in residential care settings, where to put it in resident rooms, for instance, so that if a fall does occur, you've got this softer compliant flooring, you know, that will basically reduce the chance of an injurious fall from occurring. Education, so things like, you know, listening to this webinar today, it's a key component of, you know, having a good fall prevention structure or program. It increases awareness, and it starts to make you think about what you're doing in your life and how, you know, little subtle changes that you can make. Helps to increase understanding that prevention is possible and falls just aren't a factor of life. We've got our environment. So some environmental risk factors can be decreased or limited with very little effort through changeable things. Things like removing, you know, rugs in your home that you might cause a tripping hazard. Widening doorways where you have an option to do that. Ramps over stairs. So when you set priorities, it's best to determine, you know, the person's, your exposure to the risk and the different changes that are most acceptable for you. Then we have different activities. This includes physical and social activities. So we all know the benefits of physical activity for healthier living, but it also helps to reduce falls. And Dr. Rabinovich even talked about things like resistance training. You know, quite often you hear people saying, oh, you know, it's the cardio, you got to get the cardio, go out and do the walks. And those are all really important, but simple resistance band training to help to increase, you know, some of the muscle in your shoulders and your arms can actually really help So if you do have a fall, it reduces your risk of injury with that fall. And then there are studies that show things like balance training, yoga, strength training, walking, dancing, taekwondo. These are all things that are super beneficial for fall prevention. We talked briefly too about things like clothing and footwear. I mentioned the slip-on slippers, preventing loss of balance while dressing. You know, what is it that you're wearing, you know, and how do you get dressed in the morning, and how easy it for you to get those clothes on and off so that you're not, you know, potentially falling over while you're doing it. Clothing that's relatively loose and easy to put on. Pants and house coats that are too long can impose a tripping hazard when you're at home. Footwear should be fitted properly. So shoes that have features, shoes the following features, you know, are really good. So a large surface area, a closed heel, not having those slip-on shoes, a load or a wide or no heel, shoes that have raised for ankle support, shoes that have a non-slip surface. They have a thin, firm sole, things that can be slipped on so that you're not worrying about, you know, shoes coming unlaced. But again, you also don't want to completely change to the point that you're wearing footwear that doesn't make you happy. And so again, it's balancing that risk. You know, you like to wear high heels and you're going out with friends, wear the high heels, but at the same time, also understand those risks. And then finally, health management. So we discussed some of the biological risk factors. So things like any medical conditions that are known to contribute to the fall, but knowing that there's this individual assessment. So some risks that can be reduced or eliminated. So things are the following are strategies that you can consider to work with your community leaders to promote good health management. So is there a referral to a specialist, talking to your physician about your medications, you know, and whether or not, you know, those can be changed. Things like encouraging good sleep habits. Go for that annual vision testing. You know, your vision is crucial, right? It's amazing. Mine deteriorates so fast now. I'm getting huge new prescriptions on an annual basis. And of course, you know, making sure that you're getting healthy, nutritious, and you're staying hydrated. So there's lots of other examples. This is really the Coles Notes version of fall prevention. You know, I'll end there and just sort of say one of the things that I was speaking to Lori about earlier was in one of the courses that I do at UVic, we have a pretty comprehensive, easy to understand assessment questionnaire that you can do in your own house. And so the nature of it is really for if you have a home health care nurse that would come in, they would help you to walk through your home, identify any potential risk factors. But it's something that you could do on your own, right? It sort of says, here's the living room, you know, what might be risk factors in my living room, and here's the bedroom, and what might be risk factors in my bedroom. Here's the bathroom, what might be risk factors. So what are some good prevention techniques, like grab bars, you know, those little lights that you can plug in that are sensor, you know, that you can plug into your wall, and they only come on, you know, when they see you walking or notices you walking past. Cheap and easy off of Amazon or at the local drugstore. All really great things to have in your home. So I'll stop there and see if there's any last questions.
Thanks so much, Bobbi. If anybody has a question, feel free to unmute yourself or put something in the chat and I can read it out. Bobbi, I will ask you to send me a link to that assessment questionnaire and I will post it on our website and print off some here at the center.
Absolutely.
Yeah. You know, one of the things that's not on the list, and this is, I find, is the biggest tripping hazard in my house is my cat weaving in and out of my legs when it's time to feed her.
It is. It's a big one. And I didn't show a video, but we actually have video footage from the long-term care facilities of where people, because one of them actually has cats roaming all over the place, which is fantastic. And we do have some of, you know, people tripping over dogs, you're getting wrapped up in the leash of the dog. And yeah, it's pretty crazy. But yeah, I thank you for bringing that up, because although I will always say so many benefits to having that companionship. Yeah, much like, they can really be a tripping hazard for sure.
And then nobody else is jumping in. So I did have one other question. I was curious, how is it that you see walkers being misused?
Yeah, it's quite often people will use them backwards, or they use walkers that don't have the built-in seat to sit on, and they'll sit on it and it will tip. We've used them where people were they kind of hold awkwardly, they hold them behind them, and they're kind of sitting on it and using it wheelchair style, but moving forward. Again, a not good use of a walker. We also see walkers that have broken wheels. People who are using walkers, that some walkers have wheels and some don't. So again, it sort of depends on what works best for you. But walkers that have locked wheels when the wheels should be being used, walkers being pushed or dragged when they don't have wheels and really they need to be lifted, to carry that momentum. Yeah, lots of situations where it was the walker themselves that really caused the fall in the first place.
Thanks. Any questions before we wind up here? I'm not hearing anything, so I think we will end now. And Bobbi, thank you so much. It was really informative, and it was a lot to consider. And I did want to mention that in early 2023, we're still in the planning stages, but we want to do an event probably online on how you can prepare your home for aging. So Bobbi, I may reach out to you to attend that. You probably would have some awesome suggestions on preparing your home as we age. Yeah,
absolutely. I mean, I am a gerontologist, and one of the big things, like I said, I encouraged my parents to move in with us, and so they moved out of their small rented condo. We bought a house that actually had a ground level suite, and we're able to really take into consideration what the home looked like, knowing that we wanted them to be able to live out the remainder of their life there. And potentially us living out, like we moved downstairs and, kids or somebody else in the community lives upstairs. But yeah, I would love to be part of that. My father, I have so many stories to tell about him, but, yes, he did pass away in August of this year. But, he ended up losing both of his legs in those last few years of his life. And so we had to make tons of modifications. We took off doors and we put different hinges on doors to help to widen. So you don't always have to break down a wall, or really do big things to your home to customize it. But there are certain things in place. And, we took out the bathtub and created a walk-in shower and, made sure that the home was set up in a way so there was very limited transitions and it was the same consistent floor throughout the home, which really helps to prevent, tripping hazards. And that change of flooring can sometimes confuse the mind that there's a stair or something that you need to walk over when you don't actually have to. So would love to be part of that because I've been through it and where we made tons of modifications to our home. So that was good for him.
Well, I will be in touch. And thank you again for taking the time. And thanks to everybody who joined us today. If anybody in there, if you want to put your email in the chat, I'm happy to send you a link to the video because there's lots in there and you may want to watch it again or share it. But it also will be on our the Machosen Seniors YouTube channel, probably in a day or so. Okay, everyone. Bye for now and be safe.
Thanks, Lori, and thanks for sharing your story, Karen. I really appreciate it. And thanks everybody else who turned up today.
Thank you.